Okay guys, Assalamualaikum and a very good morning. Okay, today I want to share with you about how to identify the early stage of critically ill patients, early stage of ill patients in the ward, not necessarily in surgical department. You can detect it as early as an emergency department or other disciplines. Okay, have you heard about the terminology called SIRS? It has been there for a long time. SIRS is a short form of systemic inflammatory response syndromes. This thing actually has been slowly replaced by another TT called SOFA or QSofa. But I want every new doctors to know about SIRS, because this is very easy parameters where you can identify the patient who is at risk of developing sepsis if you don't detect it early. So what is SIRS? SIRS is, as I mentioned before, is systemic inflammatory response syndrome, and there are 4 parameters in SIRS. Okay, one is the heart rate more than 100. Number 2 is respiratory rate more than 20. Number 3 is temperature more than 38.5 or less than 36.5. The last one is total watt more than 12,000 or less than 4,000. So these 4 parameters is very easy, isn't it? You don't need ICU, you don't need special instruments. So when you detect, when you measure all these parameters, and the presence of 2 of these parameters means it is SIRS. Okay, SIRS means presence of 2 of these 4 parameters. So how it implies in your clinical work? Okay, so knowing SIRS is whenever patients develop illness, whenever the patient develop illness, they will be initiating of the mediators with what we call an inflammatory response in the body. So to overcome this problem, I just give you example. In appendicitis, when there is an inflammation of the appendix due to occlusion or due to infections, occlusion first before they become infected. So the mediators like interleukin 1, then all these mediators, prostaglandins will initiate the reactions. Then you can start having temperature, patient can start having temperature and tachycardic. So when you detect these problems and measure the heart rate of the patient is 110, for example, temperature 39 at the beginning, so you know this patient is already in SIRS. So what is the benefit of identifying SIRS earlier? So you can stop the process, because SIRS, if you don't stop, it goes into shock. How it goes into shock? Like this. So SIRS is like a cycle. So when you have first insult, like I said in appendicitis just now, there will be release of mediators like prostaglandin, interleukin, and this will give you signs at the beginning: temperature raise, tachycardic. The cycle is like that. So you intervene early. You know this patient has SIRS, you intervene, identify early, put up for surgery. So you remove the cause there, you remove the appendix, and then patient recover back. Patient will be well, discharged home. So that means there will be interruption at the middle there. So that is the importance of identifying SIRS at the beginning. Okay, let's say patient didn't come to the hospital, the SIRS is already set up, nobody intervened. So there will be secondary insults here, secondary insults there. There will be release of another mediators which is contradict or completely opposite to the functions of the first. The first mediator is a good mediator, good inflammatory response. The second insults release the other mediator, which is bad. This is like oxygen radical, free radicals, other types of interleukins. So this will cause further damage to the tissues, and they can damage the end organs like lung, patient will develop ARDS, or other kidney, and they can initiate the infection. So here the infections comes, and you can have bacteremia or other things. So if we don't intervene SIRS here, the patient will go into sepsis. SIRS plus documented bacteremia, mean you take blood CNS, is considered sepsis. Okay, that will result in poor outcome of the patient, morbidity. Okay, when sepsis already set up, then you can have all the spectrums. Patient can go into shock, multi-organ failure, where the mortality can increase up to 90%. So, can you see the benefit of identifying SIRS at the beginning? So you can prevent patient from going into sepsis. You can prevent patient from going into shock. So, see another patient is, for example, burn. You identify a patient burn. So burn, there will be loss of fluids, there will be leaking of fluids. So you identify early, you resuscitate early. So what are the things that you need, obstacle you need to remove? So you need to hydrate. You need to start maybe blood spectrum antibiotic. You need to do fasciotomy early, before patient going into sepsis. So SIRS, burn, appendix burn, even cholecystitis, alveolitis, or at the beginning of UTI, when you see these two parameters positive, that is SIRS. We don't want to treat sepsis, we want to treat SIRS. So many patients in the ward, when you do rounds, you must identify this problem. So when you round, is my patient is at SIRS or not? If not, good, I can have a good night's sleep. If you have SIRS, inform your MO or specialist. Boss, I think this patient is having SIRS, we need to do something. That is a mark of a good doctor. Okay, people are moving away from SIRS. They have new parameters, new scale, what you call SOFA. SOFA, complicated. QSofa. QSofa, they simplify the SOFA. Another things where they measure the, in QSofa you have three things to measure. One is where the patient is hypotension, remember HAT, hypotension, A, altered mental function, and T, tachycardic more than 22. See, hypotension is already late stage, it's evidence of shock. Altered mental function also is already late, delayed, it's already evidence of shock, and tachycardic more than 22. This is QSofa. Presence of 2 means QSofa positive. So they are replacing SIRS, but I find that this QSofa is already, you are identifying patient at shock rather than you identifying patient at the initial stage of illness. And then after QSofa, you stratify again with the more complicated SOFA. There are 6 parameters, all measuring the end organ, kidney, glomerular filtration, measuring the lungs, measuring the liver, all the bilirubin level, blood pressure, mental function, GCS, and the score is summer. If more than 2 positive, mortality increase as 40%, like that. So it's more like management of shock, and you need mean arterial pressure, you need ABG, you need partial oxygen, you need ABG, all these things. And so far is appropriate if you manage patient at critical center like ICU or HGW, but very difficult to measure in the ward. And QSofa, okay, you can measure anywhere, but it's like measuring the whether this patient is in shock or not. So don't completely throw the SIRS. SIRS is not completely absolute. It's good for doctors in the ward, especially house officer, medical officer, because you will save patients from going into shock. Beginning, you will save patients from going into shock. So I hope you understand. This is very general. Go and read what are the type of catecholamines, good catecholamines that or mediators that benefit during the initial stage of SIRS, and what are the secondary insults. What are the type of mediators that producing secondary insults. So by understanding the principle of SIRS, you can save patient from going into shock. Thank you very much. So I complete my ride this week. So another 10 kilometers. See you again.